Good evening, everyone. Thanks so much for coming out. The house clock, I just want to let you know, is 5 minutes fast, so we're really not starting late. We really try to start on time and end on time. My name is Denise Vignon with Howard Center, and welcome to the Marna and Stephen Wise Tulin Fall Community Education Series, Marijuana Legalization or Not. That's with a question mark. Even though Howard Center is not taking a position on legalization, we are hosting tonight by request of past attendees and as part of our educational series, which aims to provide the public with easy access to information, education, and discussion. Tonight's session is not intended to be a debate, nor is it intended to be an endorsement of any of the views presented. We have done our best to ensure that a wide range of views are represented, and we acknowledge that some perspectives may be absent from the discussion. Our format will be a panel presentation, and we are in very good company with our 6 panelists who will introduce themselves as part of their presentation. Immediately following their presentation, we'll have Q&A and discussion. For your audience participation, we'll come around with microphones to ensure that the videotape quality is very good, and also to ensure everyone in the audience can hear the discussion. So even if you think you talk loud, I'm going to ask you to use a mic. We'll end promptly at 7:30 p.m. Thank you very much to our sponsors, Blue Cross Blue Shield of Vermont, our host, dealer.com, and VCAM, our friends from VCAM. We have Joey in the back, in the middle, and we have Bill over behind the camera. Thank you very much. Other housekeeping notes: the restroom is right around the corner, and we'll have an usher help you there if need be. Our community ed schedule is in your folders, so please come on out for one of our other sessions in October or November. You'll also find slide decks and resources from our presenters in the folders. And it's now my pleasure to introduce someone who needs no introduction. She is a popular and highly regarded radio journalist, known both nationally and here in Vermont for her work on NPR and VPR. A Harvard-educated native Vermonter whose career in public radio began at NPR in Washington, D.C., and was later based on the West Coast before her return to Vermont 10 years ago. Each day, she brings us informative interviews, interesting perspectives, and news as host of VPR's award-winning Vermont Edition. She's been the recipient of several awards, including our local and popular 7-Day Daisies for Best Local Radio Host and Best Talk Radio Show. We are so lucky to have her with us this evening. Please join me in welcoming Jane Lindholm.
So I'll just be speaking for about 45 minutes or so, and then we can get started. Thanks, Denise. I appreciate it. I'm really thrilled to be here. Of course, this is a controversial subject, and everybody has an opinion, and some people have facts. And I'm hoping that our panelists today are here to provide both. And just before we get started, I'm curious how many of you in the audience feel like you have a very strong position already on legalization, pro or con. Raise your hand if you have a strong position. You don't have to tell me what it is, but do you have one? So it looks like maybe half the audience. So that's interesting. So I'll be curious if you feel like your position has shifted at all. Maybe the ground feels a little less stable or more stable after this. I really feel tonight like my job is basically just air traffic control. So I'm going to get out of the way, and I'm going to let each of our panelists introduce themselves. Some of them have slides. My job is to keep you to time. So you each have 8 minutes, and I will come and yank you away from the microphone if you go over. I have been deputized by Denise. And then at the end, we will have time, a good half hour or so for questions. So keep that in mind. We'll do questions at the very end for everybody. And without further ado, let's get started with Artie.
Hey everyone, my name is Artie Seelig. I am the State Trainer and Quality Assurance Coordinator for a program called ESPERT. Before I go on, I just want to say pretty clearly that despite the logo on my slide there, I do not represent the state of Vermont or the Department of Health or the opinion of those organizations. Okay, I represent my own opinion and those of the people I work with. First of all, ESPERT as a program, part of what we do is that we go into medical settings. We try to talk to medical professionals, encourage them to ask their patients about substance abuse, and then teach them how to effectively intervene if patients report risky substance use. My background comes from a couple of different places. First of all, I was a research neuroscientist, and then I worked in higher education for a little while before switching to social work. So I sort of bring a couple of wide-ranging fields here. Okay, so a couple of things. I want to get started by talking about policy just a little bit, because policy and public health influence each other. And so this is a slide that I stole from John Kelly from a recent presentation. And what you're looking at here are the health and social problems. At the bottom on the x-axis here, you see different types of policy approaches to cannabis, from strict prohibition to full legalization up here. And one of the things you'll notice is that if we look at health and social effects, and this is a schematic, obviously, we can see that on each end, there are significant negative effects to public health, right? And when we have full legalization, you can imagine what happens when corporate profits take the place of health considerations. We've certainly seen that in different industries. And on the opposite side, we can see the same thing for strict prohibition. And I would argue that a lot of the place that we're at today is attempting to wrestle with where this is. I suspect that most people agree that strict prohibition has been a difficult road, right? We can see that based on experiences with things like alcohol. All right. So I also want to talk a little bit about where our information comes from. So we can only know what we research. Our information on cannabis in particular is highly skewed toward correlational data. What that means is that we're making associations without experimental data. So often what we're doing is we're trying to say that one thing happens and B follows it, and they may be related. As an example, let's say I go to an NBA game, I see 7-foot-tall players. I can make the assumption that being tall makes you good at basketball. That may or may not be true. Or maybe I'll reverse it and say being good at basketball makes you tall. Right? Those are equally true assumptions based on correlational data. It's also really difficult to study this experimentally, and this has been one of the major challenges. And this is largely due to difficulties within the legal and bureaucratic system, and I'm not going to get into that. But what that means is I'm going to hedge a lot, right? It means that a lot of information is not complete. We can't say we know things for certain. And so I'll speak to that in a little bit, but hopefully we keep that in mind. Right? We're sort of all here because cannabis is a controversial issue. Jane already said that. And one thing I want to point out is that when we talk about things within controversial issues, there's a tendency to oversimplify and demonize our opponents, right? They tend to look like this. Anyone remember who this is? Cruella de Vil, right? She wears jackets made of puppies. She is the worst. I'm going to ask you to think about cannabis as neither panacea nor plague. I'm going to ask you to weigh the evidence as best you can. I'm also going to encourage you to hold that ambiguity and ambivalence, right? Incomplete information, uncertain claims. Just try to listen to even the opposing viewpoints, because I think that's really important for us to be able to have a productive conversation. All right. I have like 4 more minutes to cover a huge topic. So I'm going to just speak about a few things. You all have my slides. I've listed the areas where I believe there are the greatest impacts on public health, both positive and negative. This first slide includes the negative, and that's really mostly where I'm going to stay right now. So driving. Driving, the World Health Organization considers this perhaps the biggest area of public concern with cannabis use. And yet the studies on this are difficult to line up. We know that intoxicants of any type make you a worse driver, right? We don't want people who are intoxicated in any way on the roads. And I think that's a pretty fair assumption that that's also what we would want when it comes to cannabis. On the other hand, a lot of studies on this have had difficulty, after being controlled, showing large effects for cannabis. They tend to show small negative effects for cannabis, meaning that people get into more accidents if they've been using cannabis. Lung health, interestingly, there's no evidence to show that there's a cancer risk from smoking, even though 90+% of people primarily use it that way. However, it does have significant negative influences on lung health besides that. So things like bronchitis. Short-term cognitive effects, again, want to take just a moment to say something about this, because I think it's missed in the considerations of whether or not when people quit in the long term if there are negative effects. Short-term memory effects, in particular for developing adolescents. People in high school can have significant long-term impacts even if they don't impact IQ over the long term. Think about it this way. We know that somebody who's high basically has difficulty with memory, learning, and attention. If that person then goes to math class, they're unlikely to be awesome at math that day, right? Now, if you think about it from that perspective, adolescents, 16, 17-year-olds who are in high school, those days have a dramatic effect on their life's trajectory, right? A lot of the patterns of behavior that we have in that period maintain over the course of life, and this is one of the considerations to have around adolescent use. Also, if it becomes a coping strategy, as a method for people to manage difficult emotions. Social anxiety and suicidality, I don't think these data are incredibly strong, but they're ones that concern me the most. And I suggest that based on the references that I have at the end, people look into that, because I think it's an important topic. And dependence and addiction. So dependence certainly happens. Now, I work with a lot of clinicians, and one of the things that we see, and also in the literature, is that dependence is incredibly varied from person to person, meaning one person may experience significant negative impacts. They might have sleepless nights. They might be very irritable for weeks or even greater than a month at a time, right? They could have real negative impacts on their life and their ability to function. Other people literally report more vivid dreaming as their only withdrawal symptom, right? That is remarkable. And so one of the things that I say to clinicians when we talk about this is to trust your clients. Trust the patients that we're talking to. If someone describes their experience to you in one way, it's worth keeping that in mind and trusting them and trying to hear them out. In terms of positive and medical sides, remember I mentioned that there wasn't a lot of experimental data or that it was difficult to do? Some of that is reflected in how short this list is. There is not a lot of data on the medicinal side. These are probably the three areas of greatest or strongest influence or greatest evidence at this point. So management of chronic pain in particular. And we've seen survey studies here in Vermont showing that people who have access to medicinal marijuana are able to reduce some of their other medications, including opiate medications, to manage chronic pain. Oh? Close on time? Great. All right. This is not an exhaustive list. That should go without saying. The last thing I want to point out is a much discussed, quite controversial issue, or study rather, that came out in 2010, produced by David Nutt and his group. And what they did is they took experts and they asked them to rate based on their expertise on 16 various, I don't know how to even describe them, 16 various possible negative effects of these substances. And they looked at everything from alcohol to LSD and khat. And you'll notice that cannabis falls in somewhere in the middle here. Whereas alcohol has the most significant negative impact according to their judgment. Now, I'm not going to interpret this for you, but I think it's valuable to consider, right? It's also worth considering that as more people use it, these impacts might increase. The social impacts might increase, right? Lastly, you have two references in that slide deck. These are large reports. Both have come out within the last year. I think especially the World Health Organization paper does a wonderful job of summarizing a huge area of research that I have just barely touched on. Thank you so much for your time. Thanks to the Howard Center, and I look forward to all your questions.
Thanks, Artie, and I look forward to questions too. Jennifer, come on up and introduce yourself. Or you're not even going to come up. You're just going to sit. Fine, stay right there.
All right. Can you guys hear me? Is this microphone good enough? Yeah? Okay. My name is Jennifer Morrison. I'm the Chief of Police in the town of Colchester. And tonight I'm here to represent the Vermont Association of Chiefs of Police, of which I am the president of that association. The Vermont Association of Chiefs of Police represents 60 municipalities. We are the leaders of the men and women who interact with Vermonters across the state on a daily basis. We're in schools, homes, organizations, special events, and most importantly, we're on the highways and roadways of this state. We see firsthand how drugs impact the safety and well-being of Vermont communities. Historically, our membership has not supported legalization of marijuana. That position has shifted from a no, in fact, an emphatic hell no, to not yet in the past year. Not yet, slow your roll, let's get some longitudinal data from other places has been our plea. Given that legalization may be inevitable, we do want to be part of the discussion about a responsible path forward. And we've been given a lot of thought. We have given a lot of thought to the things that we believe should happen before legalization takes place. We've created a document that we've entitled Benchmarks Pre-Legalization of Marijuana, and it's been shared with the governor's office. We believe that there should be no less than a 2-year statistically significant reversal and decline in the number of major crashes due to marijuana-impaired drivers. We believe there should be no less than a 2-year statistically significant reversal and decline in the number of DUIs related to marijuana. We'd like to see 100% capacity for in-state analysis and toxicology testing related to cannabis. We do not have that currently. We would like adoption of legislation and standards for saliva-based testing for the presence of marijuana that are accepted by the courts, and passage of a law indicating the DUI standard of impairment as the person is impaired to the slightest degree, and abandonment of any attempt to qualify nanograms per milliliter as a new standard for DUI. We'd like to see increased public service announcements to educate the driving public about the dangers of driving while impaired by marijuana or polysubstance abuse. We'd like to see no less than 2 years of statistically significant reversal and decline of underage use after the creation, implementation, and full funding of school-based education and prevention programs with evidence-based strategies and messaging. And we'd like to see legislation creating a felony-level crime for any processing or manufacturing of concentrated extracts, such as BHO or similar derivations and/or substances. We also feel it's important for the public to be fully informed about what is happening in other states that have legalized marijuana. There's a few facts to keep in mind. The average THC level of recreational marijuana in 1978 was 1.37%. In 1988, it jumped to 3.59. 10 years later, 4.43%. In 2008, it had doubled to 8.49%. Currently, the average THC level of marijuana available in dispensaries in Colorado is 18.7%, with many strains containing THC up to 30%. This is not your grandma's ditchweed. This is a totally different drug that we're talking about from what some of you might remember from your youth. This is not surprising, as the more money that, I call it Big Tobacco 2.0, which is the marijuana industry, pours into the marijuana industry, the more money they pour in, the more addictive and the higher the THC rates the product will become. Because the goal of big marijuana is to entice as many people as possible into using their product for as long as possible. It is just another GMO, and in Vermont, we have fought vigorously against GMOs. These are genetically modified products, and I'd like to think that Vermonters are smarter than falling for the advertising and gimmicks that led so many Americans down the road of lung cancer, emphysema, and all the many detriments that big tobacco brought to America. 45% of Colorado's sales of marijuana are edibles. Brownies, gummies, bears, sodas, you name it. We're not just talking about allowing adults to smoke in the privacy of their home. We are talking about introducing foods and drinks that are difficult to discern from regular products and are easily acquired by children. But most importantly, we need to talk about highway safety. Highway safety is compromised when marijuana is legalized. Post-decriminalization in Vermont, the rate of drugged driving is increasing in Vermont, just as it did in Colorado as they went down the path to legalization and post-legalization. Between 2005 and 2015, cannabis accounted for 25% or 1/4 of all drug recognition expert evaluations in the state of Vermont. In 2016 alone, that rate had jumped to 33%, or 1/3. And after dropping for 4 years, the percentage of impaired drivers involved in fatal crashes in Vermont has gone back up above 50%. In 2016, that percentage was 56.3% of drivers involved in fatal crashes that were impaired by alcohol, drugs, or a combination. Delta-9 or THC is a large piece of that increase. Colorado saw a 145% jump in the number of drivers involved in fatal crashes who tested positive for marijuana between 2013 and 2015. Marijuana was legalized in 2014 in Colorado. In 2013, the number was 47, and then we had legalization. In 2016, the number was 115. The Vermont Association of Chiefs of Police is firmly committed to public safety. In fact, the men and women of our agencies are prepared to give their lives for it. We feel strongly that highway safety concerns need to be adequately addressed before Vermont legalizes marijuana. We do have experiments. You talked about we can only measure what we can only make conclusions about what we research on and what we have, where we have experiments, what we research. We do have experiments happening out there in the United States. They're happening all around us. And I say, let them play out and make informed decisions based on reliable longitudinal data, not on the interests of big money and special interests of people who have a strong bent in that direction. There's so much more that I'd like to say, but I recognize that our time is short. I hope that as we continue to discuss this issue here and statewide, that Vermonters will use common sense and discernment to determine what is in the best interest of our communities. Most of all, I hope people will get involved and educate themselves on the issues and speak up for what they believe to be the best interest of our state. I look forward to taking your questions. Thank you.
Thanks, Jennifer Morrison. Shayne, you're on.
Hi, my name is Shayne Lynn. I'm the Executive Director of Champlain Valley Dispensary in Southern Vermont Wellness. I'm a resident of Burlington. I've been involved in medical marijuana for probably about a dozen years at this point in the state. I started by going down to the State House and being involved with the committee meetings and kind of raising my hand and being a part of the conversation down in Montpelier. I just wanted to give a quick overview of the dispensary program in the state. A lot of people don't know about it, and I just wanted to give you some background on what the dispensary program is. It's been running since 2013. We're vertically integrating, meaning everything that has cannabis in it, we manufacture ourselves and then dispense. There's currently a dispensary in Burlington, one in Montpelier, one in Brandon, one in Brattleboro. There will be a 5th dispensary announced, maybe even this week, and then there are plans for an additional dispensary at some point in the future. Currently, there's no advertising allowed for dispensaries. Eligible conditions, you have to have a qualifying condition to get onto the program in the state of Vermont. Some of the big ones are cancer, MS, HIV, AIDS, glaucoma, Crohn's. PTSD was just added last year. You have to use a healthcare professional and you have to go to a healthcare professional. You have a qualifying condition. You have to have a 3-month relationship with this healthcare professional. They have to be an MD or a DO, a naturopath, a PA, or a nurse, a registered nurse. I'm going through this pretty quickly. 8 minutes is pretty quick. Back to what I said earlier, you have to have a 3-month relationship with your healthcare professionals. When you go to see the healthcare professional, if it's your first time, they have a physical, you go through a normal doctor's visit, you would have to come back in 3 months and see them again before they could verify that you qualify for a medical marijuana card in the state of Vermont. There are some conditions if you have been diagnosed with a terminal illness, cancer, etc., in hospice care, that 3 months is waived. Also in the state of Vermont, you can have a caregiver be the person that either picks up the cannabis for you or grows cannabis plants for you. You have to have, you're subject to a criminal background check. You have to be 21 years of age. You have to be a state resident. And it's a 1-to-1 relationship. That's a really big factor. In Maine, it's more like a 1-to-5 or a 1-to-8 relationship. In Vermont, it's 1 caregiver to 1 patient. In Maine, you can be a caregiver and take care of up to 5 people, maybe even more people. And that's really created kind of a large black market in the state of Maine. Methods of consumption. This is one area, as the chief was just speaking about cannabis and the strength of cannabis, it really has changed. Cannabis today that we grow is nothing like the cannabis in the 70s or 80s. I would say that a strain that is 18% THC is definitely on average, and we do have patients, though, coming in looking for higher THC strains. One of the big messages in education, though, in cannabis as medicine is it's not just about the THC. More THC doesn't make it a better medicine. It's really about the whole plant. And what what the plant is made up of. And the plant is also made up of a whole bunch of other cannabinoids and terpenes. And it's the combination of these different cannabinoids that make the medicine useful for people. As you can see, we have dried flower, sublingual, ingestion, topicals, and transdermal patches. They all have different onset times. And with that, you also then have to have an understanding about those onset times. If you take an edible, you have to understand that it might take up to 60 minutes for you to feel the effects of it. So if you're going to get into a car and drive somewhere and you've just eaten an edible and you've gone out and you think you're going to run some errands, you should really be thinking ahead about how you use this medicine, because you don't want to be downtown shopping when the full effect of that edible comes on. So there's a lot of education that needs to take place in using cannabis as medicine. Again, current regulations, I just wanted to highlight how many regulations are in place for the medical program and compare that to the adult usage market. I call it the adult usage market out west instead of recreational. Recreational kind of gives it a sense of partying when a lot of people don't use cannabis that way in the adult market. But currently here in the state of Vermont, everything's clearly labeled, sealed, and it has child-resistant packages. We do all the testing in-house. We don't have third-party verification yet. All purchases are tracked, so if you come into the dispensary, you'll make a purchase, and we will monitor that. And the state of Vermont is regulated currently by the Department of Public Safety, which is basically the civil branch of the state troopers. And they have lifetime access to that database, so they can see what purchases are happening live. And they can also go back in a person's history to see what they've purchased. You have to be a Vermont resident to be part of the Vermont program. You can purchase up to 2 ounces every 30 days. Home cultivators, this is new this year, can also purchase at the dispensary. That allows them to come in and buy something if their crops fail, basically. CVD, Champlain Valley Dispensary, is really a part of trying to prevent diversion. And we also, back to the education component, it's really one of our priorities when someone steps into the dispensary to understand not only the program, but how to use cannabis as medicine. We're talking about the adult usage market. I just wanted to kind of give some comparisons between the two things. Right now, the medical market has been in place for roughly 4 to 5 years. It's pretty complex. There's probably over 100 pages of rules and regulations to govern it. It's going to become even more complex when adult usage comes. There are going to be 2 different markets, most likely, one for medical and one for adult. They might have different rules and regulations. How to simplify that, because that'll be important for patients and customers at that point. Medical and adult users are seeking different experiences, obviously. And so how do you educate both of those customers about how to use cannabis smartly? Back to just responsibility. And how do you start to teach Vermonters responsibility in using their cannabis? Different demographics. Currently, our average age is 55 that uses the dispensary program. It's going to be a younger demographic that comes and starts to use adult marijuana. Expanding list of digestion methods and formulas. That list I had earlier about all the different consumption methods, that's going to continue to grow. If there's one thing that's really moving quickly right now in the cannabis industry is the formulation of using the oils that the chief talked about. That is the highest growth area, and our research and development is going into that area. Local zoning and store locations are a real concern. I recently tried to, we're in the process of expanding here in Burlington. We thought we had a location picked. Landlord was mostly on board. And then he put it to his tenants. And we sat down with his tenants and we talked. At the end of the meeting, the tenants decided they didn't want to have us as another tenant in the building because they were worried about the future. They were okay with medical, but they weren't okay with the adult market, because they didn't know what was going to come. And the landlord was concerned potentially about the market value of his building. So one thing we haven't mentioned yet is CBD. CBD is the kind of the non-intoxicant, non-psychoactive cannabinoid from cannabis or from hemp. It is really trending right now. It is big. It's really big. And it's very useful for a lot of people. It has medicinal values. It doesn't get you high when you use it. it's going to have an effect on the future market here in the state of Vermont. Currently, there are a lot of hemp farmers in the state, or roughly 82 hemp farmers that have applied for a license to grow hemp in the state. They're going to grow this hemp, and then they're going to turn that hemp into CBD products, basically. Just like THC, you can put CBD into a lot of different products, all the way from cookies and brownies to coffees, and I wouldn't be surprised if people put it in the spaghetti. So it's gotten, you know, it's where do you draw a line and what you put it in, basically. Out of time? All right. I just wanted to highlight, we just recently were part of Vermont Governor's Highway Safety Program. We were approached by the traffic, I'm not sure if it's title actually, state trooper who was working on bringing highway safety to Vermont. They saw a program in Colorado that was working, so we ended up working with them to create this flyer that we put out at the dispensaries in the state of Vermont. Again, that safety component is really important for people. Even if they think they understand cannabis, again, the strength of it now, it needs to be explained to people about how best to use it. Thank you. I'll wrap it up.
Thanks, Shayne. John, you're next.
Well, that's me, and that's who I am. I'm the Substance Abuse Research and Policy Analyst and the chair of the State Epidemiological Outcomes Work Group. And unlike Artie, I'm actually representing the Vermont Department of Health. I recently attended this National Cannabis Summit in Denver, Colorado, and I'm going to channel John Calkins here. And John Calkins, you may not remember the name, but he is the lead author of the RAND report that the legislature requested called Considering Marijuana Legalization Insights for Vermont and Other Jurisdictions. So just don't think of me up here. Think of me as John Calkins. He's much smarter than I am anyway, so that's a good thing. And what he says is there's 3 surprises to date in the legalization history. That is the proliferation of the extract-based products, which is upwards of 80% THC. The consumption increase comes from a greater intensity of use and not much, so much of higher prevalence of use. And industry lobbyists are replacing do-gooders as the drivers of legalization. This is a slide that shows the number of daily and near-daily users, and in 1992, there were 10 times as many people who used alcohol on a daily or near-daily basis compared to marijuana, and now the ratio in 2015 is down to 1.9, so that's of concern. Another thing that he talked about is there's been a lot of information in the news about why didn't youth rates of marijuana use rise after legalization. Many people predicted that that was going to be a real problem, that when marijuana was legalized, that adolescents would, the rates of use in adolescents would increase. So the boring reasons was, well, it wasn't legalized for them, and second of all, the news media misinterpreted a lot of the data. The interesting answers is that legalization is not an on-off switch. It's a slow cultural change. The actual counterfactual to rise is decline in use, not stability, which I'll show you in a minute. And the increase was masked by a reduction in tobacco smoking. I'm not going to get into that part of it because I only have 8 minutes. Okay, so the question is why no rise, but rather is not why no rise, but why didn't youth marijuana use fall? As you can see, for alcohol, for getting drunk, and cigarettes, all the rates have fallen over time. DUI is down 50% for 18 to 20-year-olds. Juvenile arrests fell for serious crimes and most other offenses. So the question is, why didn't marijuana use rates fall for adolescents? I'm going to shift gears a little bit here now and talk about the relatively small number of daily users who dominate and use and use-related harm. Is there a pointer? Did I miss that? Okay. Anyway, just look at the last column for now. This gets a little complicated. The bottom 2 bars are daily users and those who use 21 to 29, and that's the amount. Those are the ones who are consuming most of the marijuana in the country, and that's of tremendous concern. Also, the escalation in dose size that has been talked about. Actually, the average in Washington State, after analyzing 33 million purchases, and is 20% for regular cannabis. For the extracts, it's over 60%. That's average. So if back in the good old days, one joint each weekend night before 2000, assuming 0.4 grams per joint at 4% THC, that gives you 4.6 milligrams per day. The average daily user in Washington State today, assuming 1.3 grams per day of 20% THC, that's 260 milligrams per day. That's a 60 times increase in THC. Now, to put that in perspective, 1 ounce a bottle of Diet Coke has 76 milligrams of caffeine. To get 60 times as much caffeine, you'd have to drink 30 16-ounce Starbucks cappuccinos. And I think the lethal dose is somewhere around 4,000 milligrams. So this is an issue. So the intensity of use and the increase in the THC content is of tremendous concern. This is a slide that's a little complex, I guess, but it's the solid line with the squares is the actual blood THC content. The dotted line is people's perception of intoxication and confusion. So as you can see, the THC content drops off relatively quickly, but the intoxication level stays for quite some time. So that's also an issue, and that's what Jen mentioned in terms of measuring nanograms. The percent, well, it's not actually per se, but in Colorado and Washington, it's 5 nanograms, and it's not really an effective measure. What happens if cannabis is removed from the Controlled Substances Act, or if it's federally legalized? This is quite an interesting scenario. So unless there's a specific congressional exemption, cannabis as a drug would fall under the regulatory authority of the Federal Drug Administration. And these states that are legalizing marijuana have lots of restrictions on advertising, on the type of products you can use. For example, Washington does not allow homegrown marijuana. And all these would become unconstitutional violations under the Interstate Commerce Clause or the free speech provisions of the U.S. Constitution. This is a very complicated issue. And what John Calkins recommends is a horizontal integration, unlike what Shayne said. And horizontal means that there are different people who control production, dispensing, and sales. Distribution, sorry. And that's another important factor. It's like how alcohol is sold in this country. He thought it should be run as a nonprofit with a board of directors made up of child welfare advocates and have a triple P bottom line, which is people, planet, and profit in that order. Thank you.
Next we have David.
Good evening. My name is David Mickenberg. Grew up in Burlington. I'm an attorney, father of 2, married to my wife. My parents are here too, and happy to be here. So I'm, I guess, representing the marijuana reform movement here tonight, and I wanted to just lay out sort of where we are in the country and where we are. I get added time. Thanks. Thanks. So I'll just get right into it. Currently, there are 29 states, including the District of Columbia, that have legal marijuana for medicinal purposes. There are 8 states, including 2 in New England, Massachusetts and Maine, where marijuana is set to be sold for non-medicinal purposes to adults 21 and older. And for some of you that don't know, Canada is set to legalize marijuana throughout the entire nation by July 1st of 2018. So by July 1st of 2018, Vermont will have Canada, Maine, and Massachusetts all with legal marijuana sold to adults 21 or older. Attitudes towards marijuana around the country and in Vermont have shifted over time. Currently, the most recent data says that 61% of Americans support legalizing marijuana, and 88% support legal marijuana for medicinal use. That's the highest recorded support for marijuana in the history of this CBS News poll. In Vermont, we've seen numbers relatively close to that, with somewhere between 55 and 57% of Vermonters supporting legal marijuana and around 30 to 33% opposing. And recently, as many of you may know, there's been multiple bills passed by both the House and the Senate in our legislature, supported in a tripartisan way by legislators furthering the policy of marijuana legalization. I just want to talk for a few minutes, since seems like I'm already running out of time, about the goals of the marijuana reform movement. And I would say there are three. First, ending the failed war on marijuana that has particular negative impacts on communities of color and poor communities throughout Vermont and the nation. I think the second goal is to better protect and educate our youth. And the third goal is to increase public safety by focusing resources on where they're needed the most, on things like violent crime and public health interventions to address drugs and drug abuse. Just for a historical context, I found this quote interesting. John Ehrlichman, who some may remember as President Nixon's White House domestic policy advisor, talked about the birth of the illegality associated with marijuana. And it wasn't a product of reason, medicine, science, but it was really a product of politics. And he said, he had, in a lengthy quote, very revealing, talked about the reason they criminalized marijuana heavily was, and I'm quoting, so that we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. So that sort of set the stage for our modern marijuana policy. And we've seen that reflected in Vermont and throughout the nation, particularly when it pertains to communities of color and poor communities. Even in Vermont, we've seen rates much higher in terms of arrests and stops for African Americans in Vermont, both pre-decriminalization of drugs, of marijuana, and post. In fact, the most recent study, 2016, said that Vermont had the third highest racial disparity in drug possession rates in the country, despite being nearly identical in terms of use rates. We've also seen in a Driving While Black or Brown report that the University of Vermont put out, they found significant disparities in how African Americans and Hispanics are stopped, searched, and arrested as compared to whites and Asians. So this remains a significant criminal justice reform issue. It's not just about bringing big marijuana to the state of Vermont. I'm glad there's been mention, oftentimes we hear our youth as the reason why this shouldn't happen, that somehow our system now is working ideally to protect youth from marijuana and the harms associated with marijuana. The Washington Post recently reported that, in fact, despite the 29 states which have made marijuana legal for medicinal reasons and 8 that have made it available to adults 21 or older, where now teen marijuana use has fallen to a 20-year low. So despite increased availability to adults. As the previous speaker mentioned, in places like Colorado and Washington, we have not seen a rise in access or use of marijuana by teens and adolescents. And even in the District of Columbia, which has does not have a tax and regulate system of marijuana, but a grow your own system, we have also not seen commensurate rises in use. So that's encouraging. Ultimately, I think what we have to ask ourselves is whether we think the current system is working best to protect individuals that are consuming marijuana and the rest of us, the public. And I would argue that is not. In fact, if we really wanted to protect folks, we would look at what we're doing vis-a-vis alcohol. The U.S. Department of Health and Human Services estimates that 25 to 30% of violent crimes in the U.S. are linked to the use of alcohol. That translates to about 5 million alcohol-related violent crimes per year. And by contrast, the federal government doesn't even track violent acts specifically related to marijuana use, as the use of marijuana has not been associated with violence. Right now, there are about 80,000 Vermonters who acknowledged to the RAND the authors of the RAND study, of using marijuana on a monthly basis. That's about 1 out of 6 of our fellow Vermonters. And it constitutes a marketplace of about $125 to $225 million a year. I would argue that the taxation and regulation of even a segment of that market would provide significant resources to invest in all of the common goals that we share: youth access prevention, law enforcement for folks committing violent crimes, drug treatment, and proper education, so we can talk with Vermonters and teach Vermonters about how to reduce the harms associated with marijuana abuse. So the question for me isn't about whether marijuana will be available in Vermont. It is available in Vermont. The real question, the one that we must decide, is whether our current system is best equipped to deal with the harms associated with marijuana, which I would argue it is not, and how we can work together to develop a system that meets our common goals of public health and public safety. Thank you.
And in case anybody missed it because his mic was off, David is with the Marijuana Policy Project, and he didn't even take his full 8 minutes, even at the added time. That's right. And lastly, we have John Porter.
Hello, my name is John Porter. By my calculation, this gives me about 40 minutes now to talk. Is that correct? I am a family physician. I am the director of the Center for Health and Wellbeing up at the University of Vermont, which, among other things, includes the mental health care and primary medical care for undergraduate and graduate students. So I want to make clear that I'm not speaking in any capacity for the University of Vermont, but I have worked with a young adult population for somewhere around 25 years now, both here at the university and at Princeton. And so my interest in the issue is both what I've seen in the medical literature and how that correlates with what we see play out pretty much on a daily basis at the university. I do appreciate the conversation. I'm grateful for these kinds of forums where discourse can happen and people can present their best information and there can be conversation. So I'm grateful for that and for everybody's participation. Now, I'm a member of 2 of these organizations. These are 6 organizations that about a year ago in January came out against legalization. And I would say that just for the general gist of what they were saying, it's not that these organizations favor prohibition. It's that the organizations are concerned about the health and well-being, as we all are, of the state's population. And we would really like us as a state to be intelligent and measured in how we approach this issue. I'm going to focus tonight on a population that is of special concern to us as Vermonters, and that's that population: middle schoolers, high schoolers, and young adults. And the specific concerns have to do with 3 areas for me. One is the issue of cognitive development. The second is the correlation between early and regular cannabis use and the development of mental health vulnerabilities. And the third is addiction. In terms of cognitive development, you know, this arm that I'm waving here is not the same arm I had when I was 20 or 30. That it has developed and remodeled itself. And we now appreciate through advances in neuroimaging that the time between basically late kind of childhood, single digit, up into age 25 is a really important time for development of the brain. That this schematic represents changes in the brain from age 5 up through age 20 years and the volume of gray matter. So this process, the brain gets a little bit bigger, but mostly it's a rewiring, it's a reconnecting process. New connections are made, old connections are pruned. This goes up probably into the mid-20s and later in males. My wife would tell you it goes on much later than that based on her experience with me, but you got to take that with a grain of salt, I think. Not going into details, but again, correlative associations that seem to be substantial between early and regular use and the development of anxiety disorders, depressive disorders, and psychosis. And again, we see this on a regular basis in our work at the university. Addiction is an issue which I think does get undersold with cannabis and conversations about cannabis, but it's very real. These numbers mirror our experience in the state of Vermont as well, that most admissions for younger people to treatment centers, this is national data, are related directly to the use of cannabis. There's a well-defined use disorder, a study about 5 years ago at the University of Maryland, 3,000 incoming first-time, first-year students. Among all students, 9.8% of them fit the diagnosis or fit the criteria for use disorder. If they reported use any time in the past year, that number went to 25%. So use disorder is real. It has real implications for day-to-day life for these folks and for long-term achievements. Withdrawals, similarly well discussed, or well described rather. It's hard to get off. And I have a slide coming up a little bit later that talks about kind of the course in this college life study, which talked about the prevalence of cannabis use disorder. But this is tough. There's a subreddit that is devoted to people who are trying to get off cannabis. And in that college life study, we can look, this is over 4 years, 70% of those individuals don't change. They're having trouble with it. They're not able to get off it. They're trying to get off it. They see some connection between use and outcomes in their life. And so just a tough situation for those. In the college setting and truly in the high school setting, there are direct impacts. It affects grades. It affects likelihood of staying enrolled. So you get this kind of overlapping pattern of alcohol use, cannabis use, mental health challenges that have kind of a graded impact on the student's experience. And it ends up with some gap that develops between an individual's potential and what they're actually achieving. So in the undergraduate years, I may have started out to be a mechanical engineering major, and the classes aren't going so well. I'm skipping classes. I'm not getting the grades I thought. I'm not going to pick on another major. I'm not going to walk into that trap, but it has real impacts. And these are insidious, hard to kind of discern for the person in the middle of it. That's not overt problems like we see with alcohol. But I can tell you any hour of any day that we're open in the medical clinic or the counseling area, you can walk down and somewhere in one of those rooms, there's somebody who's depressed, they're taking their SSRI, they're not going to class, anything else going on, well, they're smoking every day, right? And yet helping those folks make the connection between the impact of that activity and their functionality is really tough. Concerns about the context of a legalized environment for marijuana, concerned about wider availability, the impacts of commercialization, messages to young people, and the potency. Chief Morrison and others have talked about potency. This is a slide we used to use before legalization in Colorado and Washington. And the main thing to look is back in 20 years ago when the potency was around 3%. And back in the 70s when I was in college, it was probably 1.5%. So this, compared to what we see in Colorado, where here's a display with a THC concentration 16%, and a news article from last year talking about concern about limits to potency from the commercial lobby. I think it says the average for extracts is 62%. This is just uncharted territory for the human central nervous system. And I'm concerned that the drive for profits will make us as a society to make some bad decisions. Incidentally, there's been an increase that's disproportionate of cannabis use among people with lower incomes. All to say, my concern is that between the cognitive developmental kind of challenges, the mental health challenges, the addiction, I'm concerned that we will create another group of people who in our society are invisible. We don't talk about these issues. We're talking about a psychoactive, addictive substance. How are we going to handle that as a society? How are we going to do that in a humane way? It's not that prohibition has to be the answer, but we really have to be smart about our approach to this. And so are we being honest? Are we clear about our motives in the push for legalization? Have we taken real stock of the intangible costs, the treatment costs, the economic cost to a small state when people aren't functioning at their optimal level? And are we doing right now the best we can for people who are challenged by these things? I'd really love to see the creative energy that's gone into cannabis legalization put into figuring out how to help people early in their life with early childhood intervention, supporting families. And that would be a really fascinating intervention to me. So I'll stop there. Thank you.
Thanks, John, and thanks to all of you for your presentations. My head is actually swimming with questions, but I promised Howard Center I would let other people ask them tonight instead of me. So we're opening the floor to questions from you. We've got about a half an hour for that, and we're going to pass a microphone around. So does anybody have a question? And yeah, why don't we do a question right down here in the front with the gentleman in the hat? And while we do, while we're getting there, Chief Morrison, you mentioned that your organization and the chiefs of police are advocating for a roadside test. Is that something that you're working on advocating for regardless of legalization, or is this really a push if legalization happens? Because we already have impaired drivers on the road.
Right, no, you're quite right. And yes, we would like to see adoption of roadside testing, whether or not legalization passes, simply because of the, as I said, the uptick in the number of cases that we're experiencing that involve either a THC or THC and something else. So yes, we would like to see that. And again, it has to be accompanied by legislation that recognizes that this is a valid instrument, because the cost of the current testing kits, they exist, but the cost of them is exorbitant currently, and to not know if they'll be accepted as in the courts is one thing. We also have to parse out not just that there's the presence of THC, because the way we detect alcohol is very, very different. We know a lot about alcohol and impairment, and we've studied it under controlled settings for decades and decades. The way marijuana and THC is broken down is very different, and it's not stored in the blood. So I could theoretically pull Shayne over, and if I did a measurement of his blood, it would show the presence of THC. But because THC is stored primarily in fat cells, not in blood, that really doesn't speak to the level of impairment that he's experiencing at the time of operation. So one of two things could happen. I could overestimate, just by the presence of marijuana, his level of impairment if I don't have satisfactory other roadside clues, or I could underestimate it. So there's a lot more that needs to go into this, in that the level of impairment needs to remain to the slightest degree, because this 5 nanograms per milliliter that is being used out in other states it was a completely random number. There's no science behind it. In fact, of the THC average in 2016, when we got blood back after DRE examinations, was 4.2 nanograms per milliliter. And 42 out of the 62 that we made arrests for and got blood work back on, 42 of the 62 came in below 5 nanograms per milliliter, yet both the police officer at roadside and the drug recognition expert detected enough impairment to charge the person with DUI. So we need to abandon that notion in Vermont, because it's a fallacy.
So we'll go right to the questions. I could do follow-ups, but...
Okay, I was just wondering, is there any studies about people who take SSRIs or mental health drugs and the interaction of cannabis THC?
John Porter, do you have?
I can't cite any off the top of my head. I can say that there is an association between regular use of marijuana and the development of a depressive disorder. I've not seen any studies that link the two. I know that when you're a treating clinician and somebody's having refractory depression, it's the first advice is to get off the cannabis, which is tough.
One of the problems with an illegal a system which makes cannabis illegal is that studies such as you mentioned are very difficult to conduct. So the sort of scientific and medical evidence on an issue like that is nearly impossible because of the illegality associated with cannabis now. So one of the hopes is that as we move to reform our marijuana laws, we actually can get better data on things such as the interaction that you mentioned.
Yeah, and I would just concur with that medically, it's clear we need more research. We need more latitude in terms of how to
Are
research.
there any epigenetic changes associated with THC?
Not that I can cite for you.
Dr. Porter, Artie mentioned at the very beginning of our presentations that we should be careful not to conflate correlation and causation. And when you talk about, for example, depressed young people who are taking SSRIs and also are using marijuana perhaps to self-medicate, there was sort of an implied causation that marijuana may be at play in their depression. Could it go the other direction? I mean, what evidence do you have that suggests that marijuana is a partial cause?
I think Artie is right. I think it's the problem with correlative data, right? But if you go back to where we were 50 years ago with seatbelts, we didn't do a study where we, had half of folks use a seatbelt and half not. We used correlative data to kind of refine our approach, and then we looked to see what would happen with that. So that is a problem with correlative studies. You can never assign direct cause and effect to that.
Other questions? Sure.
Oh, go ahead.
I wanted to follow up with Chief Morrison on what you said. I'm also really concerned about road safety, and given the number of substances that could impair a driver, are there general tests for impairment that are maybe not chemical-based, but can you simply do a roadside test with a driver to determine are they impaired by anything?
Yes, there are dexterity tests, field dexterity tests, and of course there's multiple levels of standard field sobriety testing. Every police officer who's full-time certified in the state is able to administer the standard field sobriety test, the walk and turn, the one-legged stand, the horizontal gaze nystagmus. Vermont is one of the first states to require that within the first 2 years of receiving your full-time certification that you must complete a program called ARIDE, Advanced Roadside Impairment Detection. And this is a much advanced program. In the curriculum, you learn even more than what the baseline roadside testing is. The ARIDEs have the advanced detection skills. And the next level up is the drug recognition expert, which is an exhaustive, that's a big certification. That's a huge commitment on the part of an organization. So what we've built is basically a human PBT, preliminary breath test, to be able to detect signs of impairment above and beyond what a regular police officer might detect, in the ability to then say, well, we need to bring in a drug recognition expert. There's only 42 in the entire state, so as you can imagine, it's not something you call in unless you're real confident of impairment other than alcohol. So there are certainly human factors that can be taken into account and articulated. The question at the end of the day is, absent being certified as a drug recognition expert, how do you actually get a conviction? You either need blood work, which is incredibly invasive in my estimation for a not extraordinary circumstance, a regular DUI, shall we say. So where do we find the balancing act between the training and expertise of the police officer at roadside being accepted in court for a conviction versus this extremely high level of that the DREs have that is accepted in courts as evidentiary? How do we find that nature of what evidence are we willing to accept as for a conviction on a DUI? And really, that's not a question for the police to answer. That's a question for the courts to answer. But we can continue to invest in human beings and their skill sets, the police officers. But at the end of the day, I think there is something to be said for science and for a combination of factors, because the humans are always going to be imperfect. There might be times where we need to have other pieces of the pie. So it's a long way of saying that, yes, police officers can articulate impairment. It's basically the same as I can still charge you and arrest you for driving under the influence if you blow an 05. If I can articulate that your operation showed impairment and that alcohol was present, you can still be charged with driving while intoxicated, even though you don't meet the presumptive limit, right? So anything above 08, is an automatic, but below 08, I can still charge you if I can articulate enough factors to show impairment. It's thusly similar with drugs, but wouldn't it be nice to have some way to augment those observations other than having to force someone to go to the hospital and have a needle put in their arm? It might cost less too.
So my question is regarding the consumables in terms of beverages and edibles. In particular, David, looking to see, are you supporting that be allowed in the process of legalization or not?
Sure, good question. It's something that Shayne talked about in terms of the education that's needed. So the bill that passed the Senate a few years ago, S-241, did not allow for edibles to be sold commercially. That doesn't mean that people aren't going to make them at home. They're not that difficult to make. So what I think as part of this process, we need to have an education campaign to make sure that people understand that when you consume an edible, a drinkable product, it could take an hour or 2 hours to kick in, and understand how to reduce the harms associated with that. Ultimately, it's interesting, the state of Washington has set up a board, and the board's task is only to approve or disapprove of edible or consumable products. And the standard by which they judge that is whether it's going to be what's called in the law an attractive nuisance. So are kids going to see a gummy bear that looks like a gummy bear, smells like a gummy bear, and frankly tastes like a gummy bear, and be tempted to consume that? Absolutely. So what they've done in Washington is say, well, you have to have things that look sort of like a palish gray, uninviting, disgusting kind of looking brownie as something which kids are not going to be attracted to. Also, and they found this in the state of Colorado, early on there was no regulations associated with edibles. And so you saw a big boom in the edible products, especially for people, because in many places you can't consume marijuana in a smokable form, especially if you're a tourist in a hotel or a restaurant, things like that. So what they did was they went back to the legislature after their initiative was passed, and they put in tight controls around how you do the packaging of edibles, how you do the dosing of edibles. So the famous story, Maureen Dowd goes out to Colorado. She eats an entire very strong marijuana cookie and has a really bad experience that she writes about in the New York Times. Well, that's the equivalent of her going out to Colorado and drinking a fifth of vodka and saying, I had a really bad experience, you know. So I think the education and frankly, the industry and regulators have responded in a way to say, well, we're going to require them to be sold in ways in which it's going to be safe for both that individual and society at large. So I think ultimately it makes sense to include those products because otherwise, they'll be operating in an unregulated environment. You won't know what's in it. You won't know the dosing. You won't know the THC levels. You won't have packaging requirements. But that may be one that takes a little time, and we ease into it with a heavy education campaign on how to safely consume.
Shayne, could you briefly talk a little bit about how you do the dosing at the dispensary? Because you try to calculate THC content, you try to calculate what a dose is, how this is going to affect people, and that's part of the education that you give to patients.
Yeah,
Sorry,
I
and then
was
you
going
can.
to bring that up when Dave said, you know, it is easy to make an edible at home, but the hard part is to get the dosage right. And so back to, you know, we have lab technicians basically on staff that we test the plant when it gets harvested. We find out how much THC is in it. Then we go to a next step of extraction. We make an oil. Then we test that oil to find out how strong that oil is. Then we add that to our edibles. Then we test the edible to see how well that oil has basically gone throughout the batch of brownies that we might be baking, and then back to the labeling, you know, that we're ensuring that every package that we put out, that there's a label of how much active THC is in the product by the milligram. We have a starting recommendation of 5 milligrams as a starting dose so that people understand, hey, this is the base, this is where you should start from, and then you can work your way up. Otherwise, it can be really overwhelming, like the story that Dave retold there. And there's no record of anyone ever dying from overdosing from cannabis, but you will feel like you're dying. It's a horrible experience to go through. It will be over in a few hours, but why it is happening, and then your system does have too much THC in it, most likely you're going to get the sweats, you're going to feel dizzy, and at that point you need to lie down, you need to be drinking water, and it will pass. But back to the education component, and Vermont being ahead of the curve. One part what Vermont could be doing now is having education programs and explaining to people the different products, the strengths of them, and again, back to the driving. This is, this is life and death stuff, and so it's important that people get educated.
Did you have a
Isn't
follow-up?
one chocolate bar like 4 doses? I've just never eaten a chocolate bar in 4 sittings, so I'd like to point that out.
Well, yes, and so if you get into dosages, and so hey, Colorado really did learn, and so one of the processes they're going through now is that any of the edibles are potentially imprinted per, with the amount of milligrams on it. So you might have a chocolate bar, and then on the
scored.
yeah, and then they're scored. So there's back to these. The bigger question is, do you want to individually wrap everything? So if it's a gummy bear, should that individual gummy bear be wrapped or packaged in such a way so that when you grab that gummy bear, it's 5 milligrams or 10 milligrams? And so that's what the industry is facing right now. I would say one thing about the cannabis industry out west in Colorado, it is really responsive to the criticisms that it's received. Even though it is financially burdensome, they have gone out, they've had to, get rid of packaging, maybe hundreds of thousands of dollars of packaging. The state of Colorado comes out with a new regulation. They have to get all new packaging, and they do it willingly. They're doing it in a way because they understand that these are really concerns that need to be addressed, and how do they be a responsible industry and govern itself. Because the one thing about the cannabis industry, it would like to govern itself. It's smart enough to know that. It's just, hey, it does take time to do that.
So thank you very much for all the answers there. The other question I had is in terms of horizontal versus vertical integration, and thinking that in the medical marijuana instance, vertical is fine, but maybe horizontal is needed for the general consumption, but I don't know what we're looking at in terms of legislation. Is there going to be division of that? That's the question.
Dave could probably speak to that better than I could. They've had different laws at this point.
So when we're talking about legislation that sets up a what we call a tax and regulate system, every state has done it differently. What Vermont has most recently in the bill, tax and regulate bill, has most recently looked at a horizontal system where there's separate licenses for growers, there's separate licenses for dispensaries, there's separate licenses for testing, there's separate licenses for product manufacturing, and I think the legislation allowed any particular entity to have 2 of those licenses, but you couldn't do all of them. So it's sort of a hybrid between those, and that's a constant conversation. What Vermont has done in their through the legislature has been very attuned. We saw the lieutenant governor here. He was a part of this, very attuned to making sure that the industry, whatever future industry there is, encompasses both very small folks that want to have a small grow operation up to larger operations, which are necessary for a well-functioning system. So I don't think vertical integration will necessarily be the model that we'll follow, and other states that had vertical integration have broken away from that just as a way of spreading out different segments of the industry.
Thank you.
Other questions?
Yeah, I had a question, and thank you guys, and thank you Howard Center for putting this on. You hear a lot about, especially more so recently, about the idea of big marijuana. And that's something that, as somebody who does study this policy and these industries and a lot of entrepreneurs in this space, medical marijuana, it seems in all these states, it's a state market. and that per the Cole memo, you cannot sell marijuana from one state to another, which makes it very unique. So I'm curious where the notion of big marijuana comes from. I mean, Dave's lobbying records are all online, and there's not a, he's a local guy. I can say as an advocate myself, there's not an industry that's funding me, certainly at least. And it's a state-by-state market. So the notion that there's big marijuana, I think, is something is kind of a fallacy. And maybe in the future when there are multi-state markets or with other substances, pharmaceuticals, alcohol, all these other things. But, because it can't move across state lines, I just don't know where that corporate structure comes from and where these people are, because I'd love to find them myself.
Have you seen the CBS 33-minute documentary called Big Pot, The Commercial Takeover, that aired in November of 2016? And Profiteer, I can't think of the name of it but it's called Profiteer Industries. Privateer, Freudian slip, But that's but one example of where the industry is heading. As you said, as they get a multi-state hold, it makes it more attractive to investors, and they're bringing in investors from the likes of the people who planted the seed money for Facebook and other major companies. So the corporate interest in marijuana legalization is not a fallacy. Is the model fully stood up the way big tobacco was back in the 50s and 60s? Not yet, but that's clearly where it's going, the same way food industries have shifted and the big corporate giants put money into advertising, et cetera, and hook people into their product. So to call it a fallacy, I think, is to ignore what's happening in Washington and Colorado. To say it's a fully developed model, no, it's not there yet. But that's why I hope we don't fall for it twice.
Right, and I do think the advertising aspect is one that, the regulations clearly are much stricter. And I guess I'd redirect the question to Shayne and ask if he's aware of other people in New England who are being approached and backed by investors. I mean, it was a nonprofit system for a long time, but are you aware of this, especially in New England, of this corporate large investment money coming in and polluting this at the local level?
I can speak for Vermont. We're still a nonprofit. The state did allow us to convert to a for-profit. Going through the process that the lawyers and the CPAs, that it's a difficult kind of process for us to get through, and in the end we may not convert to a for-profit. But that said, I guess I would say that, just because something's big, I think we're equating big with bad already real quickly. And back to my comments on the industry, I'm hoping the industry itself can regulate itself, and that back to the state of Vermont, looking ahead and understanding what rules and regulations that can put in place to make sure that it's safeguarding people when they have access to cannabis legally. I mean, the part right now is that everybody has access to it right now. It's there. The black market in Vermont is very vibrant. I hear about deliveries in Burlington. You can call someone, they'll deliver cannabis to you right in Burlington. It's kind of eye-opening. To the big part, there are. I mean, I candidly in Canada, recently the industries up there have gone public, and so these are public companies now traded on the Canadian Stock Exchange, and so they are governed by by their stockholders. They're going to have the same interest as any other publicly traded company. Back to the industry, I think, though, in each state, this is the hardest part about, I think, cannabis in the country right now, is it's such a patchwork between every state, and it's going to be that way until the federal government does something different. And so it will be hard for these companies to do this, to be in all 50 states, because they're going to have to operate differently in every state, and that's going to be a challenge to be profitable. And that goes back to the vertical integration. In the beginning, vertical integration does work, I think, as a model. But as you do start to get a little larger, which we have, there gets to be real economics at play there that really sometimes doesn't make sense for us to be vertically integrated because of the cost of that. So I don't have a direct answer for you, though, Eli.
All right, thank you. I agree with, my name is Ed Baker. I'm an LADC, a licensed alcohol drug counselor for 30 years. I agree with Shayne. I do believe that the federal government needs to get involved and regulate across state lines, because there's a hodgepodge of misinformation driving a legalization, both medical and non-medical. The Surgeon General's report, Vivek Murthy's report of 2016, says that research on the marijuana plant shows no proof of either efficacy or safety for public use when it comes to medical uses. The National Academy of Sciences in 2017 just came out with a scholarly report. They say there's potential for the use of the plant consumption, derivative of the plant, in 3 areas. Pain, multiple sclerosis, and a wasting syndrome and nausea, vomiting from chemotherapy and AIDS. There's modest proof that the plant would be effective in those areas. But they also go on to say that there's no research on route of administration, dose, physiological effect. The industry, it has a paucity of research backing up some of the claims that it's making.
So Ed, do you have a question that you want somebody to answer about that?
No, I really don't. No, I just want to make a comment. And I think another thing that this is an incredibly serious public health issue that we're facing in our country today. I have a question. When you talk about research and development, are you talking about research and developing the most profit for the most sellable product, or are you talking about research and development on the impact of your customers in terms of their health?
Our mission statement as a nonprofit is to try to.
Not mission statement, money spent on research and development.
Well,
Mission statement.
we're still really a startup company, so R&D, at what context? I mean, even just growing the plant a different way is R&D for us. And so how do we go about doing that at an affordable level? I would mention GW Pharmaceuticals in England.
Synthetic cannabinoid for Dravet syndrome was approved by the federal government.
It's not a synthetic cannabinoid. They grow cannabis plants.
It's 97% CBD, and it's effective with Dravet syndrome, and they're not even done with the research yet. They do research on whether or not it's safe for consumers.
I think you have. I'm not gonna. I'm not here to persuade you, and I think there's lots of people that. Again, the medical aspect of this. I know that we serve over 3,000 Vermonters at this point.
I know that, and you serve a lot more if we let you keep doing what you're doing.
So let me redirect here, and I know, David, you want to ask a question too, but Dr. Porter, I know that UVM is now looking at classes studying marijuana on medical use, and it's looking at the health effects. But with a federal prohibition, some of the research is limited. Should there be a way to do more federal research prior to a legalization that would allow some of that study to be done?
Yeah, I think that's a fundamental change that we need, is to open the prospect of doing good studies on THC and the active ingredients. So yes, I think that's a needed move on the federal level.
Another question?
Jane, can I?
Yeah, go
I just
ahead,
want to
Chief
reference, I appreciate his comment from this standpoint, in that when we were talking about the potency of the THC level in the plants in Colorado, the same study revealed that the CBD, or the what is supposed to be the medicinal levels, were plummeting to 0.1%. As the THC was going up, the CBD was going down. Now, I want to be very clear, the Vermont Association of Chiefs of Police does not object to medical marijuana. We have no objection with it. But let's not lose sight of the fact that as the demand for recreational or adult marijuana use goes up, the idea is to have the most potent product, because just like back in the day when it was illegal, you want to get the Maui Wowie or whatever's the hottest brand strain there is out there, right? The CBD, which is the therapeutic part of the plant, at least that's what I understand. I'm not a doctor. I'm just married to one. But that goes way down to the basement, and that's a real concern. I mean, we have no objection to medical marijuana, but let's not lose sight of the fact that when you get this, you might lose. It's a give and take on all counts, and we got to be careful to keep the scales balanced of
Although
what we're
John
trying to
pointed out,
achieve.
they're different markets. Presumably, the adult recreational market, whether you want to call it recreational or not, is a different market from the medicinal market. So there may not be any interest in having a therapeutic usage in that adult market.
And I would just add, like, the history of that is that, hey, the black market was breeding CBD out of its
Yeah.
strains until people learned about CBD. And then the big trend was, oh, we got to actually incorporate, how do we breed this back into the plant? And so back to some of our R&D is, which plants do we grow? Because they have different levels of cannabinoids. And which ones do we use for that? And then back to the process of, can you formulate to make sure that CBD is included at the level you want in your edible so that it is medicinal? So.
Research shows that 1:1 CBD-THC ratio is most medicinal, most therapeutic. The Journal of the American Medical Association cited a study in 2014 where they measured CBD-THC in medical cannabinoids in Seattle, LA, and Colorado. No, Seattle and
Ed, I want to
Los
stop you
Angeles.
because we're really
Just-
close to
just-
time.
just-
No, I do want to stop because
There was
you're really,
very few
Ed,
products.
I'm going to stop you right now
Uh,
because we
you're-
want to get one more question in before the end of the panel. Great.
So my question is kind of actually related to the image that Dr. Porter left up there, which I love, which is I read a quote recently from the World Health Organization's Alcohol and Public Policy Group, and they said that the difference between good and bad policy is not an abstraction, but very often a matter of life and death. And I think in Vermont and our nation, we've seen so much media lately about the public health crisis, derived in part because we didn't understand the dangers of creating easy access to opioid prescriptions. And I think the data that people have talked about, and just in general at this point, is also really clear that marijuana has ill effects on health and should be discouraged. So given that Colorado and Washington were really the first places in the world to legalize recreational marijuana use, I'd love to hear from the panel, what justifies the recent rush to move forward with legalization in Vermont, like other states have done, and could we take, what do you think about taking 4 to 5 years and saying we're not going to do it in the next 4 to 5 years, and we're going to gather data and we're going to look at the other states so that we can have some more long-term information about risks and benefits?
David, and then Dr.
Well,
Porter.
Amen.
Even if we accept that all those risks are there, and I think I agree with you, many of them are, the real question is whether those risks are best dealt with in a regulated system or a system of illegality. So if you think right now we're doing great and marijuana harms are under control, and that we're preventing youth access, and that people know what they're consuming safely and they know how to consume safely, then I would say moving forward with the marijuana reforms wouldn't make sense. But if you believe that we can have a system which really promotes harm reduction as it pertains to marijuana, where consumers know what they're consuming, where people aren't caught up in the criminal justice system as a result of marijuana illegality, then I think you might want to start talking about a system that looks differently. So that's what I would say. I mean, in no other industry that I know of are they asking desperately to be regulated to the highest degree possible and being taxed to the highest level possible. It's very rare. So I'll leave it at that.
And I,
It seemed like from the data that was presented here today that we were doing better before the conversations around regulation and medical marijuana started to happen. So that's all I'm thinking about. It looks like the data is showing that we're moving in the wrong direction. Why wouldn't we wait to see if that's really true?
Well, I would caution any data, including data that I provide. I mean, I can give you my sites, but there's also data the Department of Health testified this year that in the legislature that post-decriminalization of marijuana, that the numbers for teen perception of harm and teen use have gone down. So there's statistics on both sides.
That's not a good thing. Perception of.
I'm sorry, the opposite effect. The use has gone down. So.
No, it has not gone down significantly.
Okay, so you can check the tape, but I would say it's fine if you believe that we are managing this issue best in the system that we have now. I just happen to disagree with that.
Dr. Porter, do you want to make a quick statement before we go to Sandy?
I would really just express my deep concern and suspicion about the prospect of using tax revenue to generate an educational program. And I also would just comment on this dynamic that I see again and again when we testify in front of the legislature or in open forums. There's a kind of an assumption, and I think it's real in the collective consciousness, that this is happening, right? And that we're doing it, I think, mostly because of the commercial value that people see in it. And I think there's a streak of Vermont libertarianism there, right? That's all fine, but I can tell you this is a significant public health issue. And so when we neglect, when we make invisible the problems that will come with broader marketing efforts, with children seeing their parents do it, that comes with significant cost, not just in terms of treatment, which are real, but in terms of, I think, lost economic productivity, with a generation of folks who grow up using and create a gap between potential and actual. So it's just interesting to me, and I don't want to sound whiny about it, but there's something here that we're recreating. And it is that phenomenon of making things invisible. Mental health issues, addiction, we're really happy to kind of focus on the economic benefits. And maybe there are some, but I'm really concerned about a generation growing up with the message that we're giving. So it's not that it has to be prohibition, but it has to be the same as a pilot going through the cockpit before a flight. We've got to look and make sure that we have all our bases covered in terms of who's going to be vulnerable, what are we doing to support them proactively, and take it that way. It feels to me as though the economic prospect and promise is driving the ship right now.
I want to give Artie a chance to chime in here because he hasn't spoken yet during our conversation.
I just wanted to address that. I feel like one thing we're missing is that, statistically speaking, 50% of people in the United States have tried marijuana at some point in their life. Knowing the state of Vermont, how we do in this room, if this were a perfect sample, it would be more than half of you all, right? So in a lot of ways, this experiment is ongoing already. And so the results that we're seeing now, right, are essentially a product of that unique culture. So the fact that so many people, our neighbors, our friends, our peers, ourselves, have had, at some point in our lives, crossed paths with cannabis is probably part of what's driving that condition today, the consideration of legalization, the decriminalization movement, and things like that. And just like one last thing to that is that what I really appreciate, everyone here agreeing that more research is valuable. Like if you listen to what people agree on this panel about, they agree on actually most things. What they're disagreeing on is the specific place in which that policy should exist. We all agree that pure decriminalization and corporate profiteering is a negative. We all agree that pure prohibition has not worked out very well, right?
We are going to close it there at 7:35, so I want to make sure we're respectful of people's times. Dr. Steingard, sorry. And I want to give great thanks to our panelists here for sharing their time, their expertise, their thoughts. Artie Seelig, Jennifer Morrison, Shayne, Lynn, John Searles, David Mickenberg, and John Porter. And thanks to all of you for being here and sharing your thoughts as well.
And Jane Lindholm. Thank you. Thank you very much, everybody. If you all could complete your feedback forms and put them in the glass vase on the way out the door, that would be appreciated. Thank you.